There's a related question which has to do with affordability. If we can't find a way to limit insurance costs, we're all going to be on the hook because of this. If we do provide coverage, there will be subsidies required, and we will be covering those subsidies. There's one question here that says, and after listening to Ken Jacobs in particular, looking at what the Senate Finance Committee is doing to the House proposal, which started out more robust, I think. Here's a question. I'm concerned. This person is concerned that we are reducing what we're getting to something that's unaffordable and unaffordable under insurance. And at what point does what we're getting?
Yeah, I want to address that because it relates to one of the things in Jim's library talked about potentially getting worse here. One of the important things that's in every one of these bills is it sets a max out of pocket. And one of the reasons why we have so many bankruptcies of people who have health insurance is we have lots of health insurance products out there where people think they're covered, and then there's $1 million lifetime limit, and something's happened and you're over the limit, or there's all sorts of places. Either you end coverage or there's no max out of pocket on this. That reform is huge in terms of the limiting bankruptcies, all of those things. That's very good. I think the concern is when we look at and remember, people who have insurance, I think, are likely to keep it. I think it's important to note, there's a reason employers offer the coverage they do, and that's what they need to attract workers, and that's not likely to change under reform. Employers aren't likely to say, oh, now that there's this range of plans, right now they could offer nothing if they wanted. They're not going to start offering less later on. So mostly who's going to be moved into this is people who currently have no coverage. So I think on that end, we're saying, this is a big improvement. Is it an improvement as far as you could get, I think is the bigger question. And my concern more is if you're requiring somebody to buy coverage, you're telling them they have to, but then what they're getting is catastrophic coverage, and their income is at a place where they don't have a lot. Catastrophic coverage makes sense if you've got a house and assets to protect. Then there's some real logic there. If you don't, we're basically saying spend this money out of pocket for something that you can't use on a day-to-day basis. I think that's where the problem is. I could see a lot of measures that would help here. All of the bills require a certain set of preventative procedures to be included. I don't understand, and maybe someone who's a lot smarter than I am can answer this question, why aren't the bills requiring that all chronic disease management be done first dollar? In terms of diabetes medicines and asthma medicines. We've got all sorts of experiments of employers doing that and bringing down healthcare costs.
I don't understand you. Why are they doing what?
Why aren't they, right, the bills are saying that mammograms, pap smears, and there's a small set of things that have to be paid first dollar, pre-deductible, because we know that they actually have an impact over time. So there's a set of preventative measures that have to be done. But where the bigger costs are around chronic disease, and I haven't heard a good explanation for why we're not saying that in all of the plans, for example, diabetes medication or asthma medication doesn't have to be paid first dollar pre-deductible. First dollar meaning it's not, you don't, it's before any deductible. There's no cost sharing.
But I think that's likely to come out in the regs, just like they did with HSAs, where essentially. So I think that that's likely to be addressed in the regulations after a bill is put through. So, for example, with HSA plans, the high deductible plans that are allowed to cover certain types of prevention first dollar, it was later deemed that chronic disease medications were considered preventive care. And so those kinds of things could be included. I think that the politicians are very reticent to put into statute exactly what constitutes a chronic disease management drug today in 2009, because that's going to be changing next year and the year after. So you don't want that in statute.
Well, that's not right. I have HSA with a $7,000 deductible, and I pay close to $16,000 a year for my husband and me with a $7,000 deductible. And the medications are not first dollar coverage, and
So-
the mammograms are not.
No, yeah,
No,
right,
no.
so what I said is that they are allowed to be covered first
Allowed
dollar
to
and
be,
still
but
get the
they're-
tax
Blue Cross
benefit,
doesn't
but they're not
cover it.
required to be, that's right.
Not to turn this into a debate on this one topic, but the bill does, for prevention, there's a body that says what preventive measures should be pre-deductible, should have no cost sharing. One could create a body that could say those same things on chronic disease management. I haven't seen it. I mean, I get your point, but
There were, and I'm watching the clock, there were a number of questions about your proposal for a public option, basically for low-income people. A couple questions. One, would that stigmatize the program? Two, would it lead to adverse selection? Would they really have only sicker people because they're under poverty? And three, is anybody in Washington advocating anything like this?
So on the stigmatization, it would be perceived, it would be defined as a program for low-income individuals. Just like Medicaid is stigmatized today, the question is whether that would be better than not having a public option at all, is what I'm comparing this to. So yes, it would be imperfect. There would be a lot of reasons why some people would not want it. People are still piling into healthy San Francisco, despite the fact that it may be stigmatized. In terms of adverse selection can be handled by having an effective risk adjustment mechanism which shares risks, pools risks between this public plan and other plans out there. That's sort of a technical issue that can be handled behind the scenes as long as the legislation sort of allows it to be done. That should not have to be a major problem. The third part of that was...
Is anybody in Congress advocating anything like this?
I have not heard this currently, anything similar to this, though I would say that the Bush administration had been pushing Medicaid waivers in certain states that would allow buying in and out of Medicaid. So there are Republicans who have been in favor of this type of idea of buying in and out of Medicaid. So I think if it was not sold with the same highly charged language that we have today about a public option, there could de facto be something that creates a public option for these low-income populations. If it was termed differently, I think it could have political legs.
Okay. And one last question for Jim, which is what is your advice to single-payer advocates as to the role they should play with regard to the current reform debate?
That's quite tough. As an organization, the Physicians for National Health Program has looked hard at the reform efforts and is very concerned that there's nothing that organizationally we can endorse. The concern is this will further entrench insurance companies and make certain problems worse before they get better. That said, as I showed, my assessment, and the assessment of many in PNHP and CAP and many single-payer advocates, is a lot of good will come of the insurance that's being considered. So what we're just trying to do is to keep on the table, keep under discussion, maybe a floor vote on a single-payer bill coming up, the Wiener bill, or amendment, which would essentially be a single-payer amendment. And to keep it as visible as possible toward, again, ultimately down the line, when we come to our senses, having what I consider to be a strategy that will work.
down on the single payer side, there's also, Kucinich has an amendment that allows states to opt in.
Yes, that would be good.